Welcome back to the Healthcare Triage Podcast. We're very excited this week to have with us Dr. Rachel Vreeman, a longtime colleague and friend who's going to talk to us about all kinds of stuff, including her work with HIV and AIDS and Kenya and the Ampat program and tons of other stuff we're going to get into later. Before we start, though, let's recap what's going on this week in the news. The big story this week, as far as I can tell, is still CHIP. As we've discussed many times before, it's a program that covers something like 9 million low and middle income children, and it ran out of money over 100 days ago. Congress still has not reauthorized it. It's mind-boggling. They did put some money into the program to keep things going for a couple more months when they passed the last budget stopgap measure, but it's still not reauthorized. The good news, and what is news this week, is that the CBO has redone its estimate of what it would actually cost to fund CHIP, and it's now down to like $800 million over the next 5 years. That's peanuts. It's like 0.1% of the cost of the tax bill. It's $160 million a year. That is nothing. Why does it suddenly cost less? It's all budget gimmickry. It's crazy, but here's how it works. If we don't have CHIP, then people have to go to the exchanges to buy insurance for their kids. When they buy insurance for their kids, lots of them are going to qualify for subsidies. When they qualify for subsidies, we taxpayers have to pay for those subsidies. So when we figure out the cost of CHIP, it's not just the cost of providing it, but it's the differential between what it would otherwise cost if we didn't have the program. So what changed in the last few weeks? Congress passed the tax bill. As part of the tax bill, they got rid of the individual mandate in 2019. That's going to raise the cost of insurance for everybody else in the exchanges. When that happens, when parents bring their kids to the exchanges to buy health insurance, we have to pay more for that health insurance. We have to pay more in subsidies. We have to pay more money. So now the cost of not having CHIP has gone up, so much so that it almost compensates for the entire cost of CHIP itself. So now instead of just being like $8 billion more to have CHIP, it's only $800 million more to have CHIP. CHIP is much better insurance than people get through the exchanges. The actuarial value is like above 90%, if I remember correctly. And that's like, compared to a silver plan, which is like 70%. And that's it. That's if that's what parents get. CHIP has incredible outcomes. Lots of people take CHIP. It's great. It's great insurance. It's better for kids. So there's almost no reason left for Congress not to do this. It costs only $160 million with an M dollars now each year to give 9 million kids better insurance than they would otherwise have if they're going to get insurance at all. So will they do anything? I still have no idea. The whole thing is baffling. It's maddening. I don't understand why it's happening at all. But one of the major reasons to not reauthorize CHIP has gone away. Hopefully that means we'll see some movement. That's our quick review of what's in the news this week. Now let's get on to our conversation with Rachel Vreeman. Rachel has been a faculty member at Indiana University for how many years now?
10.
10 years. But I knew her even before that, when she was a resident, when she was chief resident, and then when she was our first fellow, my very first fellow. Rachel and I have done lots of research together. We have written a couple of books together. In fact, most of the books you've ever heard me talk about with Medical Myths were co-written by Rachel, and she, of course, co-wrote the BMJ papers, I should say, that got a lot of that off the ground. But above and beyond that, that's the least of what Rachel does. Rachel also directs, you gotta say it so I don't get it wrong.
I'm the director of research for the Indiana University Center for Global Health and our large research partnership in Kenya.
I'll brag for a few more minutes. Rachel is a superstar faculty member. She is internationally famous for her work in HIV medication adherence in kids in sub-Saharan Africa. She spends, it feels like, half the year in Kenya, which is one of the reasons I never see her, and a significant amount of the time that she's not in Kenya, traveling to meetings all over the world to present on her work. So let me back up and start with what is the Ampat program? Because while that's like unbelievably well known to those of us at IU, I'm sure, unfortunately, most of our listeners don't know what it is. So can you tell us a bit about that?
Ampat is a really fascinating partnership that's kind of, I think, a hidden gem within Indiana. So back in 1989, the Indiana University School of Medicine partnered with a medical school in Kenya that was just getting started, the second medical school in Kenya called Moi University. And together, out of this partnership, they grew this enormous program that does medical education with students and resident doctors and and so on, that does incredible research work and that provides an enormous care delivery system. So out of this partnership that they started now 28 years ago, they have an HIV treatment program that includes 65 clinical sites across Western Kenya. They also provide care for things like high blood pressure, diabetes, and now more and more a whole primary care population health initiative.
What does Ampat stand for?
Ampat stands for the Academic Model Providing Access to Healthcare. It's the acronym that this partnership between Moi University in Kenya and Indiana University here in Indianapolis came up with to describe this whole healthcare delivery system, but also what they do in education and research as a conglomerate.
And correct me if I'm wrong, it feels to an outsider like me, like this is a major component of the entire healthcare system of the country, that this program has grown to be a major factor in providing healthcare to huge numbers of Kenyans.
It is. The system that Ampat has helped to develop and model provides care for an area that includes 13 million people. And what's unique in it, though, is that they do partner with the Ministry of Health in Kenya. So the system that they've built up is at sites that the Ministry of Health runs. So Ampat has really become this academic innovation partner for the Ministry of Health. So they're trying out new things, trying to figure out how to make the system work, putting in place, all kinds of things are actually working in what's otherwise, not always a functioning system, and really managing to provide care that way, but in partnership with the Ministry of Health, which is a neat model, I think.
And has it expanded beyond Kenya at this point?
Ampat itself, as led by Indiana University, has not. Kenya has been our primary partnership. It is our dream, though, that this academic model would be moved to other places and replicated with the same kind of partnership and depth, bringing the power of an academic medical center to partner with another academic medical center and improve care in a resource-limited place.
So besides providing care and clearly doing a huge amount of good, there's a fairly large amount of research that goes on, and you're the director of research for Ampat. So can you tell us a bit about some of the research that's going on?
Absolutely. So our research within Ampat really helps us to inform how we best provide care in settings like Kenya, in East Africa, and in similar sub-Saharan African settings. And it's a great platform for research because we have enough infrastructure through this system of clinics and an electronic medical record system and things like that to provide data for researchers. And yet we face exactly the same challenges as people working in any of the poor parts of the world. So my own work as a pediatrician, I specialize in this idea of how do we improve care for children and adolescents who are growing up with HIV. And I can answer questions about how in a really poor place can you provide the best possible care for kids with HIV, because I have this system where I can actually try things out, study and see if they're working, and get real data to then inform places that look a lot like Kenya.
How did you get interested in that work?
Well, it's sort of twofold. One is I was always interested within pediatrics in how to really improve care for families and children in underserved settings. I was always interested in the challenges of kids growing up in poverty, whether that was in the U.S. or elsewhere. I had a broad international interest, and then Indiana University actually pulled me into the Kenya partnership because I did an international rotation there doing clinical work in the hospital when I was a resident, and it made me realize, these things I want to figure out how to best provide care for poor kids. If you can do it in a place like Kenya, you can do it anywhere.
What brought you into focusing on HIV and medication adherence?
Well, in a lot of ways, I got into HIV because it was such, I think of it as like a prototypical disease of poverty. Like HIV is a disease that most impacts poor people, marginalized people in the poorest places of the world. Even in places like the US, those most affected by HIV are those who are marginalized in some way, whether it's because of their minority status, whether it's their sexual minority status, things like that. That's who gets affected by HIV. So if you can impact that problem, you can really do almost anything with it.
So what have you been finding in your study, in your research in Kenya? Like what do you find?
So, it's interesting. I think if you can hold in mind two things about HIV, it's really important. One is that HIV is still an enormous problem worldwide. I think we often think, oh, we figured out HIV, we know to do it's not so much of an issue. There's still 36 million people living with HIV. We still lose about 1 million people a year to HIV. And, the problem is, though, that 90% of those people, especially for kids and adolescents, are living in sub-Saharan Africa. So we often just forget about it.
Right.
Now, the good news and what's amazing is that we do know what to do in a lot of ways. We don't have something to completely eradicate HIV, to cure it, but we can keep it under control. Kids who are born with HIV can lead full, happy, healthy lives. We can treat HIV in a way that it becomes something like diabetes or, high blood pressure, these things that, you have to take medication for, but you can live with. So where my work has really focused is how do we provide kids with care long-term? What do they need so that HIV is not a death sentence, so that they can live with it for a long, long time?
And what is that? What is it? What is it that you found that that they don't have that they need? What are we doing about it?
The key is that they need to be able to have access to the medicines that treat HIV, and they need to take those medicines almost perfectly every single day.
Right.
And it's hard for any of us to take a medicine almost perfectly every single day. There are different challenges when you're getting your little baby to do that, or your toddler, when you're in school, and when you hit adolescence and you kind of want to rebel against everything and you don't want to be different from anyone else. It's a different set of challenges to take those medicines. So that's really where the medicines work, but you have to take them.
So what kind of interventions are you looking into to try to make that all better?
Well, we've tried a number of different things for everything from how can we use technology like electronic dose monitoring, where we have bottles that record electronically when you open them and we know if you're taking your medicine or not, things like that. Everything from that to basically emotional and mental health support. And a lot of it ends up being helping families and helping kids wrestle with the psychological and mental challenges of growing up with HIV in a place where it's really stigmatized.
So does that work? I'm asking you because I can't remember if we've actually broadcasted it or not, but we just did an episode on behavioral economics where we talked about doing a lot of these things in the United States to try to get adults to take their heart disease medication. And they won't. When we pull out all the stops, the monitoring, the social networking, financially incentivizing them, they still won't take their medicine. And when it comes to medication adherence, the behavioral economics just doesn't seem to work. But I wonder if it's completely different in the area that you're describing and that maybe you're finding that it does work there.
For kids and adolescents in settings in both East Africa and South Africa, where I've studied them, research-wise, it seems like it works. But what seems to work is if you can provide the kind of case management, counseling support, walking families in a caring, holistic way through this challenge of having to take the medicines. Throwing, one or two things at them doesn't seem to work so much as figuring out, do they need help telling the kid that they have HIV? Can you put in place peer support groups where the kids can go and talk with other kids who are wrestling about it? These things actually seem to work in these settings. And I think some of it is, there are a few things that are going on. One is that these families have seen people die from this disease. They know that this is a death sentence. And that's still what they hear in the community is that if you have HIV, you are just going to die. And that's not entirely true. With treatment, they can live, they can do well. And so I think there is a different sort of motivation to take the medicines. And yet to meet that challenge really does seem to require some of this additional support, or at least it seems to make a big difference for a lot of people.
How prevalent is HIV in the communities you're working with?
Where we're working in Kenya, the prevalence in the entire population is about 6%. So that includes people of every age. When you focus that down to people of childbearing ages, or, we kind of think of our 15 to 45-year-olds, et cetera, the prevalence becomes much higher. In some of our counties, it's as high as 30%. So that's incredibly prevalent.
So clearly prevention is still our best bet. So
Absolutely.
What are the barriers to that?
Well, there are a lot of barriers to prevention. Some of it is just, human nature and what happens that way. One of the things, though, that I think is most interesting is that after a lot of years of pushing what we call the ABCs, abstinence, be faithful, only have one partner, use condoms, what we've found that's actually incredibly effective is if you can find and treat everyone who is infected, you are not going to have the epidemic spread.
Sure.
People who are on treatment should have undetectable levels of virus in their blood, and then they are not going to pass HIV on. And that is your best bet for prevention. Because when, even 1 out of 10 of the population is infected, the chances that you might have sex with somebody who's going to have HIV are so much higher.
Right. Oh, yeah.
And, even one encounter where you're not using a condom or things like that, like, it's just incredibly easy for the virus to pass.
We did an episode on circumcision years ago. And man, it's one of those things you never want to touch. But it was interesting because, of course, we've written about this in our books. The only randomized controlled trials that exist are like adults in places like Kenya, where they're actually trying to prevent HIV and AIDS. And if I remember correctly, they found that it did help with the prevention. But of course, that's in an area where the prevalence is so high that it's actually going to make a difference. The problem is, of course, when people extrapolate that back to the United States, those benefits are clearly not seen because of the prevalence. But is the prevalence still high enough that things like circumcision are considered as treatment or prevention?
Circumcision is considered a prevention measure in places like Kenya where the prevalence is high. What I might note that I think is not nearly as well known here as it should be, here in the U.S., is that we also have an incredibly effective prevention strategy with what we call PrEP, which is taking a daily pill of an HIV medicine every day to prevent yourself from getting infected. This is widely available. It should be offered to anyone.
This is non-infected.
Non-infected people.
So, this is where on my night, I don't
see,
even know.
Exactly. People don't know that this is out there. And, if we particularly want to push this for populations where you're at a bit higher risk, whether it's because, you're having sex in a population where more people are infected, like men who have sex with men, whether you know that you don't always use condoms, things like that, or just like to think of in general, like no one likes to take a pill, but if you take this pill every single day, just one pill, you're protected against HIV. We know how to do that today.
Does that get used in the United States?
It should be.
But does it? Like, I'm actually asking. Like, I just don't. I've never literally feel like I've heard.
The CDC recommendations are actually that should be much more widely used than it is. In fact, they have recommendations, going along with universal testing, where anybody coming into an ER, different places should be tested for HIV. Once you're tested negative, you should be offered PrEP as an option.
Interesting. Is it expensive?
It can be expensive, but it depends. Lots of insurance companies cover it, and there are lots of community deliverers of PrEP, different, nonprofits and different things who provide it for free. There are places, even here in Indianapolis, where you can get PrEP for free.
Who funds this work?
My work is funded much like your research work through the National Institutes for Health largely, although certainly there are other, foundations worldwide that are thinking about this, particularly Gates Foundation, others, that are thinking on a broad scale about what works for HIV.
And do they fund like Ampat at large, or is it just the research?
They just fund the research work. Ampat at large, though, the funding for our medicines and what provides most of the medical care, which is provided by Kenyans largely. There are maybe a dozen of us from the U.S. and about 700 Kenyan staff providing care across the country. That is largely funded through USAID, so through the U.S. government, through a particular program known as PEPFAR. And that really, 200,000 patients in Kenya receiving HIV care thanks to that.
How's PEPFAR been doing funding-wise?
PEPFAR is always in danger, or particularly USAID funds that go through this are always in danger. It's historically been a favorable bipartisan effort. In fact, it was started by President Bush.
I know plenty of people who think that is the single greatest achievement of President Bush.
I would absolutely say, for everything I might have, said about Bush, I have to absolutely say I have, myself seen thousands of people whose lives were saved because of that program. And it's, in the millions worldwide. Of course, how supporting global health is seen in terms of, U.S. interests and so on is constantly something that we're struggling with these days.
How has the recent political upheaval affected all of this?
We are definitely in flux. It hasn't affected my work as closely, but there have been threatened massive budget cuts to the National Institutes for Health. There's definitely been a lot of concern that things like the Fogarty Institute, which funds most of the global health work being done, would particularly be cut in some of what's been proposed. There's a lot of fear fear that funding for our research work, funding for some of the clinical care might go away in that. Already programs have seen shifts in terms of what they're allowed to talk about or what they're allowed to do, with especially concerns about, do they touch on abortion in these settings,
Right.
things like that.
I'm laughing. Nobody can see me smiling because I was actually thinking about political upheaval in Kenya.
Oh,
Not necessarily in the United States.
I'm of course thinking about the
that's
Kenya's
just-
worried about the U.S. upheaval as well.
Yes, I'm not denying. This is just where we realize how bizarre the world has gotten. But I was actually asking about like political upheaval that we hear in the news about Kenya.
Sure. I mean, we have had issues. So Kenya has had contested presidential elections. In fact, they had to have 2 elections this year, and there's still a lot of question about that. We've because they have had a history of violence and instability in the country around the time of elections. For our program specifically, we've been really cautious and pulled people out around those times and so on. But in reality, the clinical care program has continued to move smoothly. There haven't been any major issues in that front. We sort of spend, a certain number of weeks where we're out of the country and then we're right back at it with things going on. So we have not seen a large impact from unrest there. And in fact, Kenya historically has been a stable country within
Right.
East Africa. And so we've found it important to continue to, work on the system in that way.
And we get, I'm, as Americans, panicked about unrest in other countries, but is it overblown by our news here, or is it?
It is often. I mean, you often are seeing, pictures and video from the places where, there might be the worst few things going on. Where we work in Western Kenya, where I primarily am, has been very calm. We definitely want to be cautious when we have learners involved,
Right.
and the university has taken a lot of precautions in terms of, when we think something's going to be happening politically and really being careful. But we have not had problems. It's been an incredibly stable place. And again, the fact that we've been partnering there since 1989, we are parts of the departments in which we work at the medical school. We have a lot of close connections built up. So it's really been a very safe place for us in that way. And as we translate our work into other places elsewhere in East Africa, like Uganda and Tanzania, working elsewhere in Southern Africa and so on, we're able to take the weight of that partnership in terms of what it means that we have strong East African partner as well. And I think that gives us a credibility and in that way a safety and ability to continue in other places also.
So now I'm anticipating all the emails I'm going to get of people like, oh my God, how do I get this job? So let's talk about where do you actually spend your time these days?
Well, I do have this administrative leadership role with the medical school here at Indiana University. So I spend some of my time here. I do make multiple visits to Kenya in particular each year. And I do increasingly play an international role in in guiding research related to kids and adolescents with HIV worldwide. And so that does bring me to a number of other places internationally.
How much time do you spend each year in Kenya?
It used to be pretty consistently 5 to 6 months of the year. I now have a young baby, so it's been a little bit less than that. I've been making shorter trips, but still going back and forth. He's about to go on his 3rd trip to Kenya, and he's less than a year old, so it's not stopping me.
So how do you prevent HIV in babies?
Well, we know how to do it. So not everyone's aware of this, but if a pregnant mother knows that she has HIV, we can give her medicines that almost 100% prevent the baby from getting infected to less than 0.1%. So we can prevent babies and kids from having HIV. We should be able to wipe this out. I should be able to be put out of a job. We know how to do it. We do it really, really well when we have it in place. We need to roll out these programs worldwide.
Is it what are the barriers? Like what's keeping it from happening?
One of them is testing. So women, that's probably the biggest one, that women don't know that they're infected. And in a lot of parts of the world, women still have babies at home a lot of the time. They may receive very little medical care during their pregnancy, and it's still really stigmatized to have HIV. So they may not want to be tested. And if they're found to be positive, not all of these places allow them to have access to the medicines to prevent HIV. But if we can know that they're infected and give them these medicines, we can completely prevent the babies from being infected, which I think is an incredible thing. We talk about this goal of an AIDS-free generation, meaning that there would be no babies infected, and we should be able to do that.
Do you think we'll get to that before we get to a vaccine?
I don't know. We should be able to get to it before, but it's so difficult to really roll out, effective testing and treatment programs, and particularly in the current political climate where funding for such initiatives is only being pulled back, it's harder and harder to get to it. That being said, the vaccine research has been incredibly tricky and, it's just been a hard thing to get to.
It's funny because it's like the cynical part of me, one of our enduring themes is that like, if we could just do the stuff we know we're supposed to do, how much good we could achieve. Just in anything. And so the cynical part of me was thinking like, yeah, until we get to a vaccine but then I was struck by the guinea worm. Yeah. It's like where it's like, how like just with basic simple stuff, researchers and, activists and the Carter Foundation, all that, like have managed to pretty much get that down to like near zero. And then I have some hope that maybe we can do this stuff. But God, getting people to do what we know they're supposed to do, and that includes everyone from the healthcare system on down, is so hard.
Yeah. We know what to do with HIV. We know how to prevent infections to babies. We frankly know how to prevent infections among adults. We know how to prevent infections with injection drug users. We know what to do. And once you have HIV, we know how to treat it effectively. Right. We can't cure it yet, but we know how to keep you alive and well. And yet getting people access to those things, to that treatment, to the prevention strategies has just been incredibly hard still worldwide.
Are there downsides or side effects of that PrEP stuff you were talking about?
It has been studied in enormous populations, and the side effects are incredibly minimal.
All right, let's transition to some questions from viewers. And I should say, and I have not said before, of course, we need your questions. Go to healthcaretriage.info and submit them. It is very likely we will answer them on the podcast. So please absolutely do go. Healthcaretriage.info. And Rachel, of course, as we do with all our guests, is going to stay here and help me answer them. First question comes from Seamus. I know the consensus is that vitamin supplements are frivolous, but I just moved to Washington State from California, and everyone insists that it's so gray here that you need a vitamin D supplement. So do I need it? And what literature can I point to since they insist on the efficacy of vitamins? So look, if you were a baby, maybe. There's some evidence of vitamin D deficiency in babies, especially if they are breastfed, especially on certain diets, especially in certain places. But again, there was just another huge meta-analysis published that looked at vitamin D and the efficacy and whether it actually prevents bone injury or fracture or anything else. And it fails again and again and again. And this happens with like almost all vitamin supplements. So look, you should always consult your doctor about individual health decisions, but I can't think of a good reason. Next question comes from Steve. Apart from getting an HPV vaccine, what's the best medical advice you can give your 19-year-old son?
Use condoms.
She didn't even blink. Right to use condoms.
Have a drawer of condoms so that they can just take whatever they want and they won't feel like exactly how many are missing.
Yeah. I'm a big fan against warning of people about binge drinking as well.
Oh, yeah.
Especially 19-year-olds in college. It is just, man, it's like they're going to drink. I know I get in trouble for saying that. It's funny. Just in the news again this week was an article I wrote comparing sort of pot to alcohol, and people are still horrified and still will argue with me about how marijuana is somehow more dangerous than alcohol, which is crazy. But binge drinking itself is so bad, and so many bad decisions and so many bad things happen. So condoms and no binge drinking. Agreed. There you go. Anonymous says, I've heard a lot of buzz about the human microbiome in the news, but is this buzz warranted? Should I be asking my doctor or gastroenterologist about this? Especially since I suffer from IBS-D, I'm incredibly interested in this topic. I don't want to bias the answer, so you go first.
I think it's worth asking your doctor about, given your particular condition, but unlikely that what they're figuring out about the microbiome is going to immediately impact your health, or that there would be something clear you could do about it that's going to make you feel better at the moment.
You're so even-handed. I'm like, no way. Like, if your doctor actually has an opinion about the microbiome and tells you to make decisions based on the microbiome, then they're making it up. It's like we know so little about it at this point. It's a perfectly phenomenal area of research. I think some of the work that is being done is interesting, but we know next to nothing about what we could actually do about it or what we should tell patients with respect to it. The only I will now back up one step, is that there is some evidence that if you're taking antibiotics and you want to take probiotics because of diarrheal
That's what
side
I was
effects,
thinking about.
That's fine. That's fine. That's fine. No, and it's like, look, it's fair because it's like people can totally disagree about this. I just think we did an episode on the microbiome. I'm positive we did, didn't we?
Well, it depends on how you interpret. If you are thinking about probiotics and when they might be useful, there's some evidence there.
Someone on the internet asks, what do you suggest I do when my doctor seems to be pushing treatments that really don't address the issue put forth, but this is the only doctor near me who I can see. They give an example. When discussing treating unreasonably heavy menstrual bleeding, the doctor suggests use of birth control. Okay. Then the doctor lists birth control methods that tend to make menstrual bleeding worse, like the copper IUD. I'm going to let you go first there.
I would agree with the idea that you would want a different doctor, but I'm also familiar with settings where you may not have access to other people. So I think if you have an understanding of what's going to work and not work in this, which clearly it sounds like from this example, unfortunately, you need to press for that. I mean, we always want people to question their doctors about, what evidence they're using, why they're making that decision. Typically I would say if you're not comfortable with what they're saying and how you're talking about that, move to somebody else. But if that's not, if you can't move to somebody else, then I would push them on it.
Yeah, I'm a huge fan of second opinions, but I will. But this is the thing too. It is really, really rare, because I'm assuming this is more of a primary care doc, where there's only one primary care doc around. It happens, so I'm not going to deny your experience,
and depending on the insurance coverage and whatnot.
Yeah, except even then, it's just sort of like call, like you'd be surprised. I mean, how often these things can work out. It's possible to change insurances, especially through the insurance exchanges, depending upon where you get it. But I would really call the insurance company, ask them if there are any other doctors you can see. Sometimes it's work. And I also would say, there's nothing better in the world than knowing a doctor or someone in the medical field that you can just ask, because this is the kind of question where if you just knew a doctor or could, send in an email to one at Healthcare Triage, you might get different answers. So yeah, definitely try to get second opinion. Samantha, what are the proven health benefits of veganism? Are there any risks aside of B12 deficiency? I'm letting you go first again, so I don't bias the answer.
I would say the proven health benefits are pretty minimal.
Yeah, I'm going to agree. Yeah. Again, proven health. But now again, I'm making no comment, and I'm sure Rachel's not on the ethics of it or the environmental aspects of it. If you are off, I think it's awesome. Go. But there's no randomized control trial.
Certainly I've seen people for whom that was a healthy lifestyle choice that led them to be in a much better position. But
totally agree.
Would it be something we, recommend for everyone? No.
No, I think you hit the big problem. B12 deficiency, potentially protein, if you're just, making sure you get enough. You can totally eat a healthy diet, though, being a vegan. There's just no question about it. And there's lots of reasons to do it, but probably proven health benefits is not one. Shannon asks, what do you think of Emily Oster's book, Expecting Better? I like her emphasis on strong research and risk-benefit trade-offs, but she takes some controversial stances on the basis of only a few studies. She's working on an evidence-based parenting book, and I can't wait to see what debates that will start. So look, I think Emily is awesome. I think that she's an economist whose book tried to use what data we know to argue about different ways that we could make decisions about pregnancy and childbirth, which I could not favor more. She came to many of the same conclusions we did, and a lot of busting some myths in the past. You're not wrong in that she's often relying on small numbers of studies, because that's often what we have. But why is it fair that people have been making these broad sweeping recommendations for years with no evidence, and when Emily makes counterclaims with a little bit of evidence, people get really upset? I come down on the side of we just don't know. When we just don't know, you go with the evidence you have, and then everybody makes their own decision. I think that's what she does for the most part. I think the most controversial things that I've heard from the book are the things where she tries to make the argument that probably small amounts of some alcohol is okay at certain points of pregnancy, that there really isn't good research for that. I don't think she's wrong. And it's funny because it's even in my book site, when you ask obstetricians in private, they seem to admit, and this is not me asking them, I'm saying there have been studies that show when you ask them in private, they go, yeah, I don't know how good the evidence really is against that. And when you ask them in public, they go, oh, no, never drink, because they don't trust people to be nuanced. We hold you to a higher standard at Healthcare Triage. But reasonable people can disagree here. I mean, it's there are people who are just, if there's no risk worth it, they don't want to touch alcohol. I'm totally fine with that. I think that that's great. Everybody makes their own decision.
Yeah, I mean, I think when you're saying there's really not conclusive evidence, you're going to either go on one side or the other of that and saying okay, then maybe it's okay, or I'm just going to be as absolutely safe as possible. But it's a huge difference when you're somebody who's actually acknowledging what exists and doesn't exist in the research versus just making a claim with nothing to support it except your confidence.
Yep. I'm sort of curious to know what other risks this person thinks that are like controversial things Emily said. Because, I probably agreed with more than disagreed with what Emily wrote. All right. Anonymous, you're getting this one because you have a baby. When we were visiting family, my sister-in-law gave us a bunch of grief about using a plastic baby bottle, even though it is or claims to be BPA free. Is a stainless steel bottle really necessary, or is she just being trendy?
A stainless steel bottle is not really necessary from any evidence-based perspective. I think there's definitely a trend to be, as safe as possible related to plastics. You see people pushing a lot of glass and stainless steel and so on. I, as a new mother, also have, felt that pressure as well. But there's not really any evidence to suggest that anything bad's happening to your baby from using BPA-free plastic bottles. And even with
I would let my kids drink out of pure BPA bottles.
I was just going to say, even any actual evidence for an impact from your average plastic is basically non-existent.
This is also where I want to, I think the danger is probably far greater that you're going to shatter a glass bottle and actually cut yourself or the baby than they might ever get from a plastic bottle. This is where it's amazing to me that we're obsessing over, even if it is statistically significant, likely a clinically insignificant feature. Babies are healthier today than any time in human history.
I might note that as a pediatrician who works in a place where babies still routinely die from diarrhea, from pneumonia, from things that a $5 antibiotic would fix, that it is hard to get too worried about, what kind of plastic your bottle's made out of.
It's only when we've done a great job of eliminating most of the true danger that we can get obsessed about. Yeah, it's like you get obsessed about the stainless steel or glass.
But parents have enough to worry about, and new parents are tired and worried and stressed enough, so don't worry about this.
Terry's asking a question. You may have answered this elsewhere, but I have a question about the healthcare effects of growing a beard. Currently, I have a full beard, which I've grown out to about 6 inches. A friend of mine told me they've read articles about how beards hold bacteria close to your face and can lead to chronic cold viruses and other things. I haven't been able to find a study that seemed to reach those conclusions, and anecdotally, I don't feel like I've had those issues in the several years I've had a beard the last several months when I've been letting it grow. I keep it neat and wash it regularly, but are there other things I should be concerned about?
Oh, bearded Dr. Carroll, I can't wait to hear you answer
minimal.
This.
Well, it's clearly he's got a 6-inch beard where he's trapping rodents. I've never heard of this at all, so I'm going to guess that there probably hasn't been a good study. Although this is one of those, there could be a study.
There could be. I've never looked up the literature on facial hair. Yeah. Frankly, from that standpoint, and there are things like bow ties versus long ties for men, things like in the hospital. But if you are a healthcare worker,
if this was truly an argument, you think there would be an argument against long hair for women.
True.
That the longer hair could trap bacteria and viruses and make you sicker.
It's not right around your mouth, I guess.
No, but your hair is there. You're going to touch your hair. You're going to comb your hair. You're going to touch your mouth.
Clearly, you need to have a special hipster hair myth debunking session that you're going to look at.
I'm going to go with no. I'm going to say, and again, this is I think that this is, now granted, this may be your friend telling you they don't like your beard, or that maybe you're not washing your beard enough, or the food's getting trapped in your beard, or something else they just don't like about the beard. But I've never seen any kind of really health advice about this at all, which is interesting. Anna says, my best friend, her fiance, and all her friends smoke. When we hang out, it's usually at our favorite bar, which allows smoke. Oh my God, where's this bar? Which allows smoking. I hate that. To see her, I have to be enveloped in a cloud of smoke for 3 or more hours, 1 to 2 times a week. It's especially troubling because I have asthma. How bad is this for my health, and is there anything I can do to mitigate the risks? Wow, you've really come up with a good one here, because hanging out with asthma around people who smoke is not a good idea.
It's not good.
Especially not in a enclosed area like a bar where everyone is smoking.
And that's enough exposure that it's potentially problematic.
Yeah, if I had asthma, I would not do that.
And even the secondhand smoke exposure, even without asthma, there's decent evidence that does really impact people, especially if it's weekly. For a few hours.
So this is where I'm going to also be let's stretch the bounds of your friendship a little bit. You're not going to make her not smoke, but it doesn't seem reasonable that the only way you can hang out is at her favorite bar where everyone smokes and you have asthma. I think they could find another bar. I think they could find another place. I think they could probably forego smoking for a couple hours to hang out with you, or even take a smoke break and go outside. There's got to be ways to do this without hanging out at that bar. If you're trying to get her to quit smoking, that's a whole other issue. Good luck with that. And I mean that sincerely, but I think you can you can push the boundaries of what you're doing without straining your friendship, to just not have to hang out in a smoke-filled bar when you have asthma. Final question comes to us from Maddie. Is there a difference between hand washing and using hand sanitizer? This is a softball for Rachel, so go.
Both are very effective. There can be differences in terms of how well you do one or the other, particularly if you're not, you don't use a lot of friction when you wash your hands with water, or you don't dry them off well appropriately, particularly using paper towels or whatnot. We had a fun look at this literature where it shows that your electric hand dryers are not as good as paper towels and other options, and potentially might even contaminate your hands if they're spewing dirty water in the high-powered way that some of them do. So actually, the hand sanitizer can be good. The thing is, though, that you need to actually get the contaminant off of your hands.
Right.
So,
and if I remember correctly, it's also if your hands are wet at all, like in areas where you might be cooking or anything else, hand sanitizer doesn't work as well.
Right.
So that's a time I think when you're cooking, hand washing is going to do better.
Exactly. Or if poop is stuck on your hands.
No, that's never good anyway.
Yeah.
That'll do it, I think. God, thank you so much for doing this.
You're
I really
welcome.
appreciate
it's
it.
fun.
We'll do our quick housekeeping. As always, Healthcare Triage is free to all of you. And we'll continue to enjoy it forever for free. That being said, anything that we can do to help support the show always works. And one way to do that is through a subscription service called patreon.com. If you go to patreon.com/healthcaretriage and you're so inclined, you can support the show with something even as little as like $1 a month or $1. We don't care. Anything helps, keeps the show going, makes all of this bigger and better, but it is not mandatory. We love you anyway, and we'll continue to do the show no matter what. Holiday seasons have passed, but still you can get lots of great Healthcare Triage merch at hctmerch.com, which is really just a quick link to get you to the FTBA because we're part of that big family. But again, that's hctmerch.com. You can enjoy any of the books that Rachel and I have written, which I don't promote as much because I've been focusing more on the new book, of course, The Bad Food Bible. Really appreciate it if you pick up a copy. It expands on a lot of the stuff that you love when we talk about nutrition here on Healthcare Triage. Thanks so much for listening. Thank you, Rachel, for joining us. It's been an absolute pleasure. We'll see you in 2 weeks.